Yes.
Thanks, Navdeep, for the kind invitation. It's indeed my distinct pleasure and privilege to be able to chair this afternoon session with the three big boys of urology. We have with us three notable people renowned in their field, namely Dr. Muhilan, Dr. Siva, and also Dr. Hemant. So first of all, let me introduce the first speaker for this afternoon, symposium number 4, which is male fertility and andrology. The first speaker is none other than Dr. Muhilan. Dr. Muhilan is a consultant urologist at Thomson Hospital. He graduated in the year 1998 and then went on to join University of Malaya as a student doing the master's program. He graduated as a surgeon from the University of Malaya and soon after that completed the Malaysian Urology Board certification exam and also the conjoined exam with the Royal College of Surgeons, having completed the FRCS Urology. He spent a number of years in the University of Malaya and he was then appointed a consultant urologist there and a senior lecturer. Having spent due time in University of Malaya, he then ventured out subsequently into private practice. Ladies and gentlemen, can we welcome Dr. Muhilan? He will be speaking to us on microdissection TC.
Hi, good afternoon, Ethan. Thanks for the introduction and thank you to MSAT for having me. Okay, hopefully my voice is nice and clear. Now I'm going to share the screen with my slides. All right, sharing now. Okay, sorry, let me go back there. Right, so because I only have 20 minutes, so let me just jump into it. MicroTC is the default operation and by right, the standard operation for non-obstructive ASO. But it's a very, very rewarding surgery and it's also incredibly frustrating. So the key thing about MicroTC is it's got to be the correct surgery for the correct patient and we have to manage expectations really, really well, right? So because most of us here are clinicians and we all handle patients, I thought I'll take you through what happens in real life with a real patient. So this chap was referred to me for azoospermia. He was 40 years old. His wife is 37. She was 37 years old and they've been married for about 5 years. So we, at the initial presentation, he was found to be azoospermic. And on examination, he had really small testes. They were only about 4 cc's and his FSH was really high, 35. LH, testosterone, not very distinctive, slightly higher than normal. And we came to a conclusion he was non-obstructive azoospermia. Now, having high FSH and a small testis is sufficient to diagnose non-obstructive ASO. So one of the things in Thomson, we have a slightly different protocol. Because this patient had already indicated that their second choice would be a donor, we went ahead and collected 10 eggs from the wife, have them on standby, and we proceeded to work up the husband to see whether he was a good candidate for MicroTC. Now, first step is fairly standard. It's basically your standard bloods, which is your FBC, your renal function, liver function, and thyroid. Thyroid function is of key. Second thing we did was we sent genetic testing. We do genetic testing for 2 reasons. You want to know the prognosis for your surgery, and you want to know what you're going to submit the couple to if you give them an abnormal child. So you need to be able to counsel them. Now, sadly, only about 15% of patients actually have anything. 85% of male patients, we cannot find a genetic abnormality. This does not mean they don't have a genetic abnormality. It just means we can't find it. If you look at male fertility specialists, commonly we all agree that there is some genetic component to why they are azoospermic. It's just that we can't find a reason why. So moving on, we did a workup for him. We did his bloods, and what we did was we then proceeded to discuss with him his options. So, like I said earlier, sorry, somebody's mic is on. Just based on his size of his testes and his FSH, we told him he was non-obstructive. He asked us, should he do a biopsy to confirm what he had? I'm not in favor of biopsies. I do not do biopsy of testes for diagnostic purposes or I do it for therapeutic reasons. Each time we do a biopsy, you create scar tissue, and the success of surgery goes down. The success of retrieving testes goes down, retrieving sperm goes down. So that's been pretty well proven. And anyway, the only differential diagnosis histologically you're going to find on a biopsy is whether this patient is Sertoli cell only, which goes for MicroTC. Hypospermatogenesis also goes for MicroTC, so it makes no difference. And maturation arrest. Maturation arrest, the testes tend to be bigger with a more normal FSH. And they are the only category of patients which do not go for MicroTC. But they are fairly easy to identify during surgery, and you can then proceed to do a biopsy if you find maturation arrest. So I'm going a bit fast because a little bit worried about time here, right? So he then asked now in this patient, he did not have any genetic abnormalities. But if he did have genetic abnormalities, the two common ones are AZF, microdeletions, and Kleinfelders. So in AZF, it's particularly important we tell them about it and we do the testing, because if they have AZF A or B, your chances of finding sperm for all practical reasons is 0. So donor becomes your only viable option if culturally allowed, or adoption. So that leaves us at AZFC. Now, it's very interesting. I can find sperm in about 50-60% of patients. And of the patients that we do find sperm, we can fertilize 50% of the eggs, or 50% of the time. And of those who get fertilized, or the embryos are the eggs are fertilized, we have embryos and we do transfers, successful pregnancy is about 45 to 50%. So overall, you go down, you're looking at overall 25-30% success rates. Now, if they have a son, take it as granted that the boy will be infertile. It's just a matter of whether he's infertile with very, very, very low sperm counts, he's infertile azoospermic, or he's sterile. This is the only outcome possible for the boy. If they have a daughter, fine, well and good, they're blessed, no further treatment required. But they do need to be counseled. So we would tell them that if you have multiple embryos, you have the option of gender selection if you wish. Now that brings me to my next group of genetic abnormal patients who go for MicroTC, and that's Kleinfelders. Now, Kleinfelders has the best outcome for MicroTC, and Kleinfelders XXY often have very low testosterone levels. And this is the one group of patients where there are a lot of papers showing that if we correct the hormone levels to more than 10, the success rate of surgery goes up quite a bit, by more than 50-60%. So it is worth subjecting these patients to hormonal therapy. For those who wish to know how to do it, which is not in this topic, just message me on the side. But roughly, it's a combination of Arimidex and HCG and Clomid. On a personal level, I like HCG and Clomid, but honestly, the data doesn't show a big difference. Again, the success rate here is pretty good. I can find sperm in 60-70% of patients after about 6 months of hormone therapy. ICSI rates are about 40-60%. And of those, we got 50% of patients are successful on embryo transfers. And the good part, there is, and this has been proven in multiple papers, there is no DNA transmission of defects to the children. So children are born healthy with whatever it is they naturally have. So Kleinfelders, even though it sounds bad, from a MicroTC point of view, has a very nice success rate, relatively speaking, for this surgery. Now, after going through all this with him, you would now be asked, or I would ask, or my embryologist would ask, is MicroTC the best option available for this patient? I've said it at the start, it is the default option. Now, this is a very nice paper. It came out in 2015, and it's quite big. It's a big paper, and it was done in one of the best centers in the world for MicroTC. So they're a bit biased. But anyway, jokes aside, MicroTC is 1.5 times more successful than conventional TC. On the caveat that you have the facilities to do MicroTC, that means you have a good embryologist, you have a good lab, you're willing to incubate sperm and all that stuff, MicroTC has a 1.5 times higher success rate than conventional TC. If you don't have the facilities, then the outcome's the same. And conventional TC by itself is already 2 times more successful than for sperm retrieval and TISA. So for me, non-obstructive vaso, TISA is a waste of time. If you're going to do it, do a TC or do a MicroTC if you have the facilities. Right. So now this, you have a patient, he's already diagnosed as non-obstructive vaso. We have gone through the genetics with him. We have convinced him that MicroTC is the best option for him. And now we're going to go and look at a patient and decide what are the things that are going to improve or decrease our chances of success. The single most important predictive factor is histology. So of the 3, Sertoli cell, maturation errors, and hypospermatogenesis, Sertoli cell only syndrome has the lowest success rate. Worldwide success rates where they select patients is about 30+%. Locally, my success rates tend to be a bit lower, around 15 to 25%. That's because we tend not to select so much. We do everybody due to cultural. A lot of patients cannot go for donor, so for closure reasons, they wish to have surgery. What about inhibin B? Inhibin B and FSH, they are indicators of non-obstructive azoospermia. That means the levels will tell you whether this patient is azoospermic or not, but they do not predict surgical outcome. Now, a patient with, say, normal FSH is, say, 5 to 10 or 2 to 10, and your FSH is now 12. But patient at lower FSH, lower abnormal FSH, will more likely have maturation arrest, which has, depending whether it's early or late, will have very low success rates. Higher FSH, you may have hypospermatogenesis or Sertoli cell, which may have a better success rate for surgery. So inhibin B and FSH tell you the patient is non-obstructive vaso. It does not predict outcome of surgery. What about genetics? Of the 2 common ones, if your patient is blessed or not blessed to have Kleinfelders, you probably have the highest chance of success. So genetics and histology are important, bloods not so much. Testicular volume. There's a small tiny testis means his success rate is low. No. I often have good results with MicroTC with small testis, and with huge normal looking testis I fail because it's maturation arrest, which has very low success rate. What about age? Okay, so the older you are, does it mean surgery is less successful? No. There's been no difference found whether I operate on someone 60 years old, 50 years old, 40 years old, or 30 years old. The success rate for surgery seems to be about the same internationally, and even in a local context, I think we're about the same. How about undescended testis? I can find no evidence that undescended testis makes any difference to outcome of surgery. Okay, varicocele. Now this one's interesting. Conventional teaching says varicocele surgery is indicated for poor quality of sperm. But in non-obstructive vaso, what we found is if the patients have done a varicocelectomy before and it's been corrected, these are clinical varicocelectomies, so grade 3, grade 4. Post-surgery, the data seems to show that they have better outcomes in MicroTC. Okay, so now we have gone through the patient, we have decided he's going for surgery, we have told him what are his risk factors, and we now know the things that predict success or failure of MicroTC. Now, when MicroTC is expensive, one, and a lot of people think it's destructive. And if you, I'll show the pictures at the end why people think it's destructive. Now, that's very misleading, but anyway, we'll come to that. So a lot of people ask, is it worth the extra time and effort and surgery, whether in terms of financial cost or morbidity, whether it's worth all that to do MicroTC? Okay, simple answer. MicroTC gives you a higher yield of sperm compared to conventional TC or TISA. And strangely enough, because of the way we do the surgery, the amount of destruction of tissue, okay, is of the spermatogenic cells or the seminiferous tubules is a lot less. So we cause very little scarring on the inside of testis. And at the end of surgery, we also have lower incidence of infection. So the morbidity for MicroTC versus conventional TC versus TISA, we have less infection, less scarring, and a higher sperm retrieval rate. So there's actually no reason to doubt that it's worth it. It's whether we can do it or it's available. A lot of patients and a lot of my colleagues have asked me a question. So, I do the surgery. Does this patient need long-term medical therapy, whether it's for hormones or usually for hormonal levels? Regardless of what we do, a good 15% of patients will need hormone replacement, especially if they're already starting out with low hormone levels. Most patients after surgery and after hormonal correction after surgery will revert back to their pre-treatment levels of testosterone. Whatever it is, whether they are low, normal, low, or whatever it is, most will revert back if only MicroTC is done. But about 15% will deteriorate and they will need hormone treatment. Okay, by the way, for all the slides, the relevant references are at the bottom of the slide, and these are the good references that I picked. Right. Okay, now we come to the fun part, the surgery itself. So as we're all surgeons or gynecologists or doctors, so we all understand first principles, right? First principle of MicroTC. The MicroTC is really about what you see under the microscope. So we use a 25 times microscope. And what you're looking for is something different. Now that something different is basically you have a huge field or a small field of unhealthy tissue, which looks like fibrous strands. And within this field of unhealthy tissue, you're going to see what you think is healthy tissue. When you first start doing, it's a bit difficult and it's very hard to explain, but basically you're looking for a difference. So you're looking whether it's slightly bigger, it's slightly fatter, is it slightly more translucent? Now, if you are Malaysian or you are Asian and you like Asian food, think of a plate of bihun noodles, which has very fine string-like noodles, and inside there you're going to find this little chubby noodle, which we call a mee, and you're going to pick that up. So we are looking for a different, you're looking for something different that stands out. And the reason this is important is the reason MicroTC doesn't work for maturation arrest or obstructive azo is because all tissue looks the same. In maturation arrest, all tissue looks the same. They all look healthy, but some will have mature sperm and most will not. So principle of MicroTC, we are looking for the different cells or different foci or meiosis in a sea of unhealthy tissue. Okay, so hopefully the Malaysian reference helped. So now, that's the principles. Okay. Now, okay, I think I made a mistake here. This slide was supposed to be one slide earlier. So, but anyway, I'm going to talk about this a little bit. So this should have been before principles of surgery. My apologies on this one. This is an important update. It came out in 2021. It was earlier published in 2020. And I find it really useful. 17-hydroxyprogesterone is a very simple blood test. Sadly, I think we send it out of the country to do it. But it's a pretty accurate indicator of sperm within the testis. It's an indirect indicator of testosterone, intertesticular testosterone levels. So normal is about 220, but if you have above 55, there's a pretty good chance you'll have sperm inside the testis, and this will help you counsel the patient for surgery. Okay, now back to surgery. I mentioned earlier, MicroTC is very much a team surgery. And the picture I wanted to see here is, this is our actual lab setup. I do my surgeries under number one, general anesthesia. Because the surgeries tend to be long, they tend to be about, at a minimum, I think about an hour and a half, and I've gone up to 4 hours if I'm feeling, I try to do I try to keep going until either I've run out of places to look or we find sperm. So a surgery can go 1.5 to 4 hours, depending. So we do it under general anesthesia. We have 2 scrub nurses, one to hold, one to retract, and one to do flushing. And most importantly, I work with a full team of embryologists. Now, the reason being, you dissect the tissue, you're going to find tissue, and in about 90+% of the time, the sample that you find, you will know immediately whether there is viable sperm. And how it's done is the embryologist in the OR will do mechanical destruction, and they'll really break it down. And you'll put some droplets under the slide and you'll check for sperm. And then the second team of embryologists will do a chemical breakdown and do further analysis. And as they analyze the samples, they will give you real-time feedback. Are you looking at good tissue? Are you picking tissue correctly? This will help you refine your surgical technique. And it will also tell you where to look. So as you get going, this really helps because it tells you that you're picking the correct tissue under your microscope. So you're improving. But it also tell you where to look. So I cannot work without the good team of embryologists. And in another 5 to 10% of people, you may not find sperm initially. So your embryologists need to consider incubating the tissue overnight. You can use pentoxifylline to incubate overnight. And hopefully you find some sperm. Not often, 10% of people. And they're not going to be the healthiest, but they should be alive and good enough for ICSI. So again, I quoted the paper at the bottom. So what I'm trying to say here is, if you wish to start doing MicroTC, you need a team and you need a good team to support you. And I'm really blessed. I have a pretty good team of embryologists and they give me really fast, really accurate feedback. And you need the equipment and the anesthetist. Now, the key points of MicroTC. I do a midline incision on the scrotum. I expose both the testes simultaneously and I'll expose both of them. It just saves time. Now, the key part here is you need to bivalve the testis. So if you look on your left-hand side of the screen, you can see that that testis has been split into half. Okay, that's a half testis. You bivalve it. And the reason you do this is it gives you very good exposure. And I use a micro dissection kit to open it up like that. You put anchor stitches and you bring in your 25 times microscope. Now, in 2/3, 75% of the time, 60 to 70% of the time, on first glance, that means without dissecting further, with just some flushing and just opening, you can usually find some foci of meiosis immediately, some thick, chubby tissue. Now, if you look at your slide on your right, I'm moving forward here, that's what unhealthy tissue looks like, line after line of fibrotic tissue. So on first glance, if you run your microscope, do it systematically from corner to corner, 60% of the time you can find 1, 2 tubules. Once you find 2 tubules, you usually have between 10 to 20 sperms sufficient for that cycle of IVF. Now, if you don't see it, what do? You dissect along the lines gently, follow the lines of blood vessels, don't tear it, and you just tease it apart. We don't have remove, we're just separating tissue out. And again, we're looking for key points of meiosis, and then we're going to pluck it out, send it to the embryologist, and they're going to process it for you. Now, this is the view under a microscope. So the screen on the left is, they're the same, by the way, the left and right screen, except the screen on the left is what it looks like under a microscope before you remove the tissue, or before you free up the tissue. Screen on the right, what we have done is we have used a forceps to gently release the fibrous tissue around the area of meiosis that we're seeing, the different cells there, the chubby, translucent, knee-like structure. And once you release it like that, you can then see the difference. And once you see that, you remove it, give it to an embryologist in the minimum amount of fluid you can get away with it. They'll do a mechanical breakdown, take the fluid, do a chemical breakdown, and you will be able to see, hopefully, you can see sperm. So the thing is, this looks very nice. I got to see something like this where I understood what I was seeing after about, well, to be honest, I think it took me about a year. So the first year I was doing was sort of like blind luck. I took whatever I thought I was good tissue. Then the embryologist used to tell me yes or no. In the last 2 or 3 years, it's by default, you know what you're seeing, so it's a lot easier. So that brings me to my final and conclusions and my final slide. MicroTC is practice. You need to start at some point, just open up, explore the tissue, and get your embryologist to give you real-time feedback. So once you've done it a few times, you can actually see it. The eye will see it because the eye does not see what the brain does not know. So MicroTC is about practice. Now, evidence will tell you MicroTC is the way forward for non-obstructive ASO. It is definitely worth doing, with the caveat that you have set up the proper team, that you have the microscope and that you have your embryologist ready to support you. Is there any other message I wish to transmit? No, I think that's about it. So hopefully that clarified some things about MicroTC. And I see Ethan is back. Hi, Ethan.
Hey.
So I'm ready to take any questions.
Sure.
Try too fast.
Yeah, well, there are a couple of questions that have popped up. So the first question, of course, is how long does it take for the testosterone levels to go back to pre-TESE levels after surgery?
Right. Let's assume you stopped. Okay, so that only applies to hormone treatment patients like Kleinfelders. So if you stop your hormone treatment, most will revert back at the earliest 72 hours later, depending on the dose you're using, but roughly 72 hours. But by end of first week, you will know what is baseline. Okay, it may fluctuate a bit more if there's infection or loss scarring, but roughly at the end of 1 week, that is baseline. And that will tell you where you stand. So end of 1 week, you're back to what is normal hormone levels for that particular patient.
Okay. At the end of 1 week.
End of 1 week.
Can I just
72 hours drugs have worn off.
Can I just ask you whether you would advocate MicroTC for all non-obstructive cases or?
Okay, so in clinical practice, right? If I have a suspiciously healthy looking testis, and I call it suspicious because if I make a diagnosis of non-obstructive ASO and the FSH is say 12, 13, borderline high, and that testis looks almost normal size and almost firmness, and get very paranoid about maturation arrest, right? So what I do is I usually counsel the patients, because once they're under GA, you can't change it, that I'll be either doing a biopsy where I'll be removing 30-40% of the testis if it's maturation arrest, to MicroTC. So what I do is I open, I explore, I check the epididymis, you do MESA, test the testis, check the testis. If you decide maturation arrest, do a biopsy. If it's not, do MicroTC. But do I straight away go in for MicroTC for all patients? No, I go in for the small testis, this really small testis with very high FSH. Then it's a waste of time to do anything else. Those patients go directly with MicroTC. Everybody else, I would still, just for completion, make sure you check your MESA, plan for biopsy.
Okay. One last question. I mean, one of the common problems that we have with all biopsy sperm is that when you freeze them for use, when the partner goes for an oocyte retrieval, there's always a complaint from the lab that frozen sperm, trying to gauge viability can be a bit tricky, and biopsied sperm are even perhaps worse. Okay, and I'm guessing that MicroTC sperm hit the other end of the spectrum. So what are your thoughts about that?
Okay, I fully agree. Fully agree the lab. So all the gynecologists I work with now, I drive them mad, because what we do is, okay, so for patients who are open to donor, that means I've already agreed to donor, we collect eggs before MicroTC, because that way the eggs are available for fertilization on the day of MicroTC. So I try as far as possible that we fertilize on the day of MicroTC. For patients who are not open to fertilization, I do a MicroTC first on the same day as the OPU. So that means if I find sperm, the wife proceeds for egg collection and we fertilize the eggs. If the wife, for whatever reason, if I fail for whatever reason, then the wife is given the option of either we collect the eggs and freeze or we just stop. So I fully agree because when I first started MicroTC, I used to do it before IVF cycles to save money because IVF cycles are cost. And I ended up more than 50% of the time when we defrost the sperm, lab will call me and tell me, all the sperms that were sort of twitchy on life support, well, they went to heaven along the way. And honestly, most of the sperm, look, we need to use sperm mobile to get them moving. They are twitchy, they're not the healthiest, strongest sperm in the world. Let me put it that way. They are already on life support. Freezing just kills them. So if you notice for this patient, I had the eggs prepped. And as a matter of practice, where I work, we do same day. So the gynecologists tell me 3-4 days in advance, they pick the date, we book the surgeries. I go first, they go next for egg collection. And honestly, our fertility rates have improved with that.
Sure. Okay. Right. Okay. I think that's about as much time as we have. Thank you so much, Muhilan, for that excellent presentation.
And thanks, Ethan. And thanks, EMSA, for having me. It was fun being here.
And we hope to hear from you more often after this. Thank you.
Hope so. I'm sending in my membership.
Yeah. Yes. Of course. Look on that.